Hi everybody, my name is Matt King with Bernalillo County Fire Department. I'm going to go over the Lifepack15 for you so you understand the features and maybe some key steps on how to deploy it for your patient assessment and how to do it efficiently. And so what this thing will do for you to make your patient interactions that much more beneficial for your patient and for you later. We'll talk about all those considerations. So thank you for joining me today. So we're rolling out some additional training on the Lifepack15 and some of the user options and how you could really make this device work well for you to bolster your patient assessment, and maybe some of the functionalities of the monitor that are maybe not being utilized by you for your assessment right now that you might actually want to incorporate as part of your clinical assessment. And also kind of point out some of the features on the monitor that are obvious, but maybe not so obvious as to why the monitor is even configured the way that it is. If you haven't already taken the time, there should be a copy of the operating instructions located at your station when the monitor was delivered. Same thing with the auto pulse. I would highly encourage everybody to take a moment with your crew and get familiar with the operating instructions. In it, you're going to find some wonderful tools. There's a DVD, and there is some cards to kind of give you some prompts for each of the devices. So I would look into that. Also, I believe we're going to be attaching a link to Physio's training video. It's lengthy, so most people probably won't be interested in watching it from start to finish. It's about 48 minutes long, but it also comprehensively goes over the functionality. If there's something that maybe you have more questions on, the manufacturer's video could probably answer those. But it's like any other manufacturer's video, it can be kind of drone on in areas that you're not going to want to sit through. So we're going to try to make this a little bit shorter, make it a little bit more operationally pertinent for how we're doing business currently. And again, keep in mind, this is not the gospel of the Lifepack15. This is our current uses and current practices that we're using, and anything's subject to change down the line. So this is only going to be as operationally pertinent as it is today versus 2019, 2020. New technologies, new techniques could emerge, so we'd be back in here trying to train you up on those. First of all, I'd like to point out some of the most obvious things about the Lifepack that are obvious but not so obvious. We've invested in some very fancy technology. We have this left side which has all the modules we've purchased. So you've got end-tidal CO2, SpO2, non-invasive blood pressure monitoring, and of course our 3-lead EKG cable. But what's interesting is that you notice how this is set to the left side of the monitor. You can really set your patient assessment off on the right foot by simply putting your patient in a position to where the monitor rests at the patient's left side. When Lifepack designed this monitor, they understood how most ambulances and rescues were configured for patient transport. Almost every single North American ambulance, and even in Europe, the patient is loaded on a gurney with their right side to the cabinets, and their gurney will be loaded with the gurney towards the patient's right side. This continually leaves the patient's left side available for serial blood pressure monitoring and serial vital signs. So Lifepack took that and wanted to make the patient assessment system very systematic. So if you come into a patient's home or a business or wherever you're going to encounter your patient, and you sort of set yourself up for assessment and intervention, within the first few seconds of making patient contact, that's going to do you well to make sure that your interventions are done on the correct side and whatnot. Now that we've said that, there are some obvious things that would interfere with that. If a patient can't have IVs on one side of their body because of a mastectomy or a fracture or some sort of other medical scenario where you can't do it this way, you're going to have to alter your assessment technique. But most people will be able to follow this sort of rhythmic pattern of how you set them up. So my suggestion is that you always set a patient in a chair or in the bed if possible, wherever you want them, and you kind of get them comfortable and stationary. This allows all the cables and assessment tools to feed out from the side of the monitor and affix them to your patient. If you were to put the patient on the right side, you would see that all of your cables are going to not only interfere with the screen and your button access, but it's going to also inhibit the printer, which may give you sort of a bad tracing. So just the very simplest method of putting the patient in a spot and setting the monitor to the patient's left side, you can see how all of your assessment tools are going to pay out to that side, and it's going to leave you nice, good access here. That's important. Now, you'll notice also that the patient's right side is still accessible for IVs, temperature, BGL, all of those other sort of invasive procedures. And then when the patient is transitioned from the home to a gurney, and from the gurney to the back of the ambulance, their left side is still available for serial monitoring. So these sort of design features that were incorporated into which side of the monitor we put this stuff on, LifePack thought about that. They wanted the whole patient interaction to kind of be seamless from start to finish. They wanted to work with us. Those are one of the items that we kind of say are the obvious but not so obvious when they roll out a new device. You may or may not have heard this before today. So what I like to do is I like to use the monitor for all of its bells and whistles on most of the patients that I'm assessing. So one of those deals is that when I roll up on scene on the MDT is I'll hit my arrived button about the time we're putting the car or the rescue in neutral and pulling the e-brake. That sort of gives us a good idea of when we arrive to the scene. But when I get my patient positioned to where I want them and I've now made patient contact is when I power on my monitor. Later, when we talk about retrieving data, this timestamp right here will give us a great indication of how long it took you from the moment you arrived on scene in your rescue to the moment that you actually made physical patient contact. And why that would be important, I mean, I don't have to sit here and spell that out for anybody. We can understand that if there was a delay, we're walking to the 3rd floor of the casino, the patient's inaccessible because they're behind a locked or closed door, we may not always remember to look at our watch when we finally make patient access. But if you just power on the monitor as soon as you set it next to your patient, you know exactly what time your patient assessment started. So that's a really good practice. Now, now that we've made patient contact and we want to use our first vital sign, pulse and pulse oximetry, we're going to be using the rainbow cable. Now the rainbow cable is a fancy and expensive cable, and it needs to be treated as a fancy and expensive cable. So when you're deploying this and rolling it up for in between patients, it should be cleaned per the guidelines, which you'll find in the operating manual. You never want to submerge this in any kind of cleaner. It tells you specifically how to wash it. You want to make sure that the pictogram here that shows the fingernail is in the up position. You never want to put this on upside down. You always want to follow. And just like any other pulse oximeter, you're going to want to use the ring finger of the non-dominant hand. Now inside of the probe is a finger stop. And you want to make sure that you slide that onto the ring finger of the non-dominant hand all the way to the stop. And then you're going to want to protect it from any outside light source if possible. So, you know, if the patient's seated and you can maybe pull their t-shirt over it, or maybe there's a towel or something nearby you can cover that up with, then you want to go ahead and do that. Now you'll notice that it takes the monitor about 30 seconds to calibrate that it sees what it's wanting to see through the infrared light, and it starts displaying a reading for you. So notice that the only thing we can monitor at this moment is pulse rate and our SpO2 reading. Now, there's a little graph bouncing off to the side of the pulse oximeter that you might appreciate. That's a very important thing if you want to consider patients who have altered perfusion state. So this would be your patient with low blood pressure. Probably this time of year in the winter and fall and spring, they're cold, so they're going to be having some vasoconstriction and not having good flow to the fingertip. And so you want to make sure that you're still touching your patients and you're feeling the temperature and the cap refill of the finger that you decide to use, all indications of whether you're going to get an accurate reading. All right? So, things that you might not have appreciated, and this is on the Lifepack15 screen, and it's also on your ToughStat pulse oximeter, is this bouncing graph off to the side of your digital readout of your pulse oximetry reading. And you'll see that the pulsatile pulsations of the capillary level, where you're actually getting mechanical heartbeats through the capillary bed, and the height of this graph right here is a wonderful indication of how reliable your number is, because you could say, well, look at that, that graph is bouncing at least halfway, if not higher, in its whole range. So I'm pretty confident that the number I'm seeing there is probably accurate. Conversely, if it's below the halfway point, the monitor is going to give you an indication that says SpO2 low perfusion along the bottom, and it's going to want you to probably try to make some troubleshooting steps. Is the probe the correct size for the patient's finger? That's be the first thing that would be wrong. So you'll notice that they give you this nice little gauge here, and I don't have to explain it any further than the pictogram. If your finger slips through the hole, you need to go to a pediatric. If it does not slip through the hole at the nail bed, then you're okay to use the normal adult size on here. So beyond that, those are the obvious functions, and we've all used pulse oximetry on every patient we encounter, hopefully. But what can the LifePack do beyond that for you? Well, this is kind of interesting. You're going to use your speed dial. You're going to scroll over to your pulse oximeter reading, and maybe you just want to see if there's an SpCO concern. So we'll let the monitor sort of cycle through and see if it sees any SpCO. And it's registering a 1% SpCO, clinically insignificant. So an SpCO reading, so beyond pulse oximetry, your rainbow cable is going to give you the opportunity to check if a patient's got carbon monoxide on board. So if you're in your clinical interview or your clinical picture that you see when you enter a home, you want to see if somebody's, if carbon monoxide is a factor, you can check the saturation of carbon monoxide on the hemoglobin versus just the saturation of oxygen on the hemoglobin. Now, what's nice about the LifePack is that anything over 10% and over is clinically significant. Like if you and I are setting an SpCO reading of 10% or over, when you power this thing on and apply the probe, this is going to flash red and it's going to say 10%, and it's going to give you a little alarm that says, hey, look at me. If it's under 10%, the monitor says insignificant. You'd rather monitor the patient's pulse oximetry reading, so it's going to leave it on this screen. Now, I want to go over and look just to make sure that I'm not missing something. So I'll scroll my selector dial over to pulse ox, parameter, and down to SpCO. And you can see that I currently have an SpCO reading of 0%. Now, I don't need to change it back because the monitor is going to go about 10 seconds and it's going to say, yeah, not significant, you'd rather watch the patient's SpCO, or SpO2, excuse me. Now, so why would I be curious to see what the SpCO reading is let's say, for instance, you roll on that patient who's saturated with carbon monoxide after being in a house or an enclosed space, whatever is happening with their appliances that would lead them to be saturated with carbon monoxide. You and I put a pulse oximeter on their finger, and what's it going to read? 100%. We're going to say to ourselves, that's marvelous, 100%. That's just where I want them to be, right? But if their CO reading is above 10%, which in most cases of this nature they would be, and this would auto-default to alarm you like, hello, look at the patient's SpCO reading, the monitor is going to do that for you. But that's what makes the pulse oximeter, the Lifepack15, superior to the ToughStat probe, the little yellow one you keep in your first out bag, because that pulse oximeter does not read SpCO, whereas the Lifepack15 will. So that's important. Now, I want you to notice I'm going to change a couple of things on the monitor. This is where we're bolstering our SpCO assessment technique. So notice the color of the numbers here is white and white. I told you now that if I only am using this device and I have not included any of the other assessment features into my clinical assessment yet, the NIBP or the 3-lead cable, then these white numbers and that white beeping pulse tells me that my SpCO and heart rate are from the pulse ox probe. What else can this probe do for me? Well, scrolling down to not channel 1, but channel 2 or channel 3 here, And by channel, I mean where you would get a normal readout for ECG or end tidal. I like to select channel 2 so that I'm still able to watch capnography later, and I'm able to see lead 2 as I continue my assessment, but we're not going to get into that just yet. I'm just still talking about pulse oximetry. If I scroll down to channel 2 and I change my waveform from none to SpO2, let's see what happens. Well, right away, you're going to appreciate a couple of changes have occurred. The numbers changed from white to blue. Now that's going to be significant because that lets me know, again, a visual indicator of which heart rate am I looking at here. Now, if I had the patient loaded up on the 3-lead cable and I was monitoring their EKG, the numbers would be green, which would correspond with the green coloration for any ECG monitoring here. That, as an assessment tool, tells me that the patient has electrical activity in there, and I'm looking at an electrical heart rate, but it doesn't tell me that the heart's actually pumping or giving me mechanical activity. So the SpO2 cable in this configuration is doing something beyond, this is actually letting me know that I have heart pumping activity. Does that make sense? So by putting up the plethograph here along channel 2, if it's subject to patient movement and artifact, but do you see that nice tall waveform and it corresponds with the heart rate? And what's fascinating about this is that you could even argue the difference between systole and diastole just by looking at this waveform, because you'll see how it sort of peaks, bumps off, and then goes down again. And if you consider the lub-dub of valves closing, that's pretty remarkable that you can see that activity indicated at the capillary level. That's nothing that's going to change your clinical course, but you can see how I know that I have a heartbeat. I don't just have electrical PEA heart activity. So that's fascinating. So that's another clinical tool for you to add to your SpO2. So we're going to move on then to non-invasive blood pressure reading. So I don't know if you want to be a patient or not.
Yeah.
So now that we have a simulated patient here, we're going to transition over to our NIBP cuff, or non-invasive blood pressure. Now, the reason that they have to make the distinction with Lifepack15 between the non-invasive blood pressure monitoring and invasive blood pressure monitoring, which would be IBP, is that there is an option here that you might appreciate. There's 2 empty spots on the Lifepack, and those are for additional invasive monitoring modules that are very expensive. They're very hard to maintain. They use those in the intensive care setting and for critical flight transport. And for instance, you would have an arterial line which would give you your real-time blood pressure moment by moment. That's an invasive blood pressure, versus the cuff, which is giving you a non-invasive blood pressure. Another module that you could have purchased with this unit would be for continuous esophageal temperature monitoring. Obviously, neither one of those pertain to the emergency medical services. Again, they're expensive and they're very hard to maintain, so we didn't invest in those. But that's why there's a distinction here between NIBP. You and I using a manual blood pressure cuff, again, that's a non-invasive blood pressure monitor, or non-invasive blood pressure technique. So that's what the NIBP stands for, if you didn't know. Little factoid. So I have my patient here. I'm going to come down, I'm going to assess her. I see she has good skin color, good cap refill, her fingers are warm. I'm going to use the ring finger of her non-dominant hand. I'm going to place the pictogram with the nail bed upright, and then I'm going to assess and protect for any ambient light which might negatively impact my reading here. And then also, yes, and also remove anything that's in the way, like nail polish and things like that. It looks like we have a good bouncing graph on the left side. We have a good pulse and a good saturation, and I also want to verify at the radial site that my beats and the monitor's beats are along with each other, the good cadence, which they are. I can verify that the patient's heart rate is where the monitor says it is, and that the pulse ox is reliable. Come down here, change this to SpO2. The color changes, giving me a visual indication that the pulse that I'm seeing is from the probe and not from the ECG, because it's not green, and we'll talk about that in a little while. And that auditory thing I'm hearing is the heart rate generated by the pulse oximeter probe, because we don't have any other monitoring in place at this point. Now, again, set my monitor to the patient's left side, giving me the left side when appropriate to do all of my assessments, and freeing up the right side for IVs or any other invasive blood sugar checks or temperature. We're not going to be fumbling over each other, and the cables are not draped across the screen and printer to reach the patient. So just by making these very quick, easy setup steps, you can see that a lot is done, and the obvious but not so obvious, and the assessment is going along swimmingly. Now, I'm the person checking vital signs, so it would be in my best interest to stay with the patient, explain to the patient what I'm doing, coaching them as, if you could hold still, keep your movement to a limit, maybe have a hand on the patient, say, I'm going to be here with you, we want to make sure we get a good assessment and that everything we check is accurate, and most people respond to that by cooperating with the clinical assessment. So now, as I deploy my BP cuff, I want to make sure that the cuff is the correct size for the patient. So if your cuff is worn out and you can't see the range indicator and the artery lines and the index line on your BP cuff, I would suggest ordering a replacement from Logistics. But this is the range line from which you will be able to determine if this is the correct size cuff for the patient. Also, you have an artery right arm and an artery left arm. The best place to place the BP cuff is to try to match the artery line where the patient's brachial artery is descending down the arm. That's nowhere near the anterior cubital fossa or the antecubital fossa. This is where you're going to find your large veins, not your arteries, hopefully. But if you go to the more medial site of the arm, that's where the brachial artery is located. I'm using the patient's left arm, so I want to find the left arm artery line, and I want to place that where that brachial artery is. Now as I come around, I can see my index line and my range, and I can see that my patient's range is going to fall right into that. If it steps outside of that range, we're going to escalate the cuff to the large adult, and if it's smaller than that, we're going to go to the small. Now, simultaneously, as I go to check the patient's blood pressure, I probably don't want to have the pulse oximeter on the same finger. So if it's possible to relocate to the other hand, that's fine, because as the cuff inflates, you're going to start getting all sorts of bells and indications over here that's telling you low perfusion, check pulse ox probe. You're going to be wondering, well, the beeping's about, and it's going to drive you a little bit crazy and distract you from what you're trying to accomplish. So we'll go ahead and forego doing that. And then now I'm going to let this thing cycle. The monitor will give you 120 seconds to obtain the blood pressure reading, and then it will time out. Another thing that would make the monitor stop the reading is if the patient's moving excessively, flexing their arm, lots of artifact from stuff like that, the NIBP will shut off. You'll get 2 dotted lines, and it's not going to do it automatically. So again, if you get your patient set up correctly, you tell them what you're trying to accomplish, you get the patient to buy into your assessment without movement or artifact, then this works really, really well. So now we have our NIBP reading, which popped up 122/81, and on the bottom left of that bank, you'll see that it gives me a mean arterial pressure reading as well. Currently in our protocol, we don't gauge any of our clinical interventions based on a map reading, but that's what that little number is in case you were curious why you're getting 3 numbers. 122/81. Now let's say, for instance, that I'm making interventions on my patient which might alter the patient's blood pressure. I'm giving them a medication which would lower the blood pressure, for instance. Nitroglycerin or morphine sulfate, or you name it. And I'm going to want to really keep an eye on this. So maybe I want to check the blood pressure every 2 minutes. So all I'm going to do is use my speed dial, go over to the module that I'm wanting to tamper with, select my interval, which is defaulted to off, and we'll want to do, well, for the sake of the presentation, let's just do every 2 minutes. Now, it's not going to start the interval every 2 minutes from this point. I'm going to actually have to hit the start, and let the BP cycle through a whole other reading, and then from that moment it will count down, and every 2 minutes it's going to give me a blood pressure. Now, when would this be a wonderful tool for us to have in patients of a critical nature? So perhaps you just ran a patient that's in shock, or just return of spontaneous circulation after a code blue scenario, and you're trying to alter the blood pressure or maintain what you've got before you load them and go to the hospital. This would be a great time to set up an interval on the patient and make sure that you're watching that blood pressure closely. It also takes all the guesswork out of it. If you want to check that BP every 2 minutes while you're making your medication adjustments to epi drips or levofed drips, this sort of helps you take the guesswork out of it. Now, that being said, just because you affix an NIBP cuff on a machine to a patient doesn't mean that you don't have a responsibility to ensure that the cuff hasn't migrated, that it hasn't remained partially inflated, which would give you a bad reading, that the patient's condition has changed and you're missing it because the monitor didn't catch it and you as a clinician didn't catch it. So by employing this on any patient, it's still the provider's responsibility to practice due diligence and making sure that they're monitoring the patient's status, not just looking at a screen to give you the numbers that you're looking for. So we set it for every 2 minutes, and you see the countdown timer is added to the screen. And here in about 27 seconds, we're going to be asking the monitor to go ahead and give us an updated blood pressure. Now, later, when I go back to the report and I'm going to have to enter my vital signs, these sorts of tools are wonderful in helping you determine the time period of which you were doing your vital signs, and it makes charting and entering procedures and medications, we're going to get into that in a little while, a whole lot easier if you let the monitor sort of do these things for you. Oh, I did want to add one more thing. The default inflation pressure on the LifePack is 160 millimeters of mercury. If you're doing a manual BP, you know, sometimes you'll inflate the bladder to until you obliterate the pulse, so you're listening as you're inflating and also listening as you're deflating. This one's just going to inflate to 160 on the first attempt. If it registers that the patient's blood pressure is higher than that, then it'll inflate a second time to 180 or 200, and that's going to take a long time to get a blood pressure reading. So how can you combat that? Conversely, if I'm checking a blood pressure on a 5-year-old, and I know that they're not going to like that squeeze on their arm at 160, then before I inflate, I may just decide to come over here and adjust the inflation pressure down to something a little bit more friendly for a pediatric, say 100 or 120, and then go ahead with the reading. And then if I am anticipating that the pressure is going to be much higher than 160, and I don't want to waste the time for the BP to cycle, then before I inflate, I'll just come over here and adjust the inflation pressure to 120, or I'm sorry, 180, and then I'll go from there. So again, it's good clinical practice to know your monitor, know what you're trying to accomplish with your assessment, and just the person who's running the monitor and getting the vitals, just set it up so that you're successful and you get accurate, reliable vital signs in a decent amount of time. Let's say that you're operating your blood pressure cuff and it's not working, and you're trying to troubleshoot what's going on, and you have some residual air left in this in the cuff. Well, it's just a quick motion to unhook it. You're going to want to deflate all the air back out of the cuff, get it nice and flat again. Make sure that it's the correct size. Make an adjustment if the patient's larger or smaller, and then go ahead and then replace the cuff and try it from there. Now, discontinuing the monitor in between uses, right? Obviously, if I was concerned about infection control and I have a sick patient, I'm going to be deploying this on my next call, I'm going to decontaminate this per the manufacturer's recommendations, wipe it down, and put it away. But in order for this to be as reliable, the first use, the 100th use, the 200th use, we want to make sure that we're putting the equipment back into the monitor and storing it in a very conscientious way. So one technique you might appreciate is I always like to just roll the air tubing without letting it kink, and I'm just going to sort of kind of roll it back on itself and protect it with the cuff and into the top pouch. You'll appreciate that the location of the pouches corresponds with the cable you're trying to store. So if the BP cuff is stored in the upper, that leaves the lower for the 3-lead ECG cable. And then as I'm putting this EKG probe away, a very expensive cable and probe, I want to make sure that I'm using diligence, and I'm not just going to sit here and wrap it up as willy-nilly as I can. I want to make sure that all the wraps are out of it. A nice straight cable. Inspect it for kinks or shiners through the insulation, and then just very cautiously find the way that the cable wants to coil back on itself. And then in the front basket here, this cable can be tucked away nice and protected. And then as we zip out here, you'll see that this leaves no strain at my connection point on any of my cables. We're ready to go to the next patient. It takes a lot, guys, to keep our equipment reliable, because you may be the next person that this monitor gets deployed on, perhaps for rehab from a fire, or worse, you get injured or something. So we want to make sure that these things are ready to go for us, ready to go for our patients that we serve. So do the best you can to take care of it. So after you've put the cables away correctly and you're going to store this back in the unit, the red and blacks, the new units that we've deployed east, and even most of our spares have a pretty good place to store this in between calls. But do yourself a favor and protect and keep clean the screens and the soft buttons here in the front, because I've gone on overtime or force hire to certain stations, and I found them in a spare unit, for instance, and this monitor is being sort of stored in this configuration. I've actually seen it barely hanging on upside down because of turns and all whatnot during just normal vehicle use. And this is a $33,000 piece of equipment, and we really would like it to be functional for everybody. So, you know, if I were you, I would treat it as a $33,000 piece of equipment. That way we can use these well into the future. Okay, I've just arrived on shift, and I'm doing my normal bag and monitor checks and truck checks and MDT checks and PPE checks and everything else that I check in the morning to get onto the vehicle. The Lifepack15 is a wonderful device. You'll notice that when you come in at 3 o'clock in the morning, not when you come in at 3 o'clock in the morning, but when you come into shift and you see a little receipt hanging out of the bottom of your monitor, you'll notice that the monitor performs a self-check at 3 o'clock in the morning, assuming that the monitor wasn't on a call, turned on, being used. If it was on at that 3 o'clock moment, the monitor will just skip that self-check for the next 24 hours, and the next morning at 3 a.m., chances are it'll be able to do a self-check. So you'll see that 3 a.m. receipt printed out hanging off the front of the monitor, and you look at it and you say, oh, look at that, it did a self-check at 3 a.m. Well, what does the self-check do for the Lifepack15? What it's done is it has essentially checked everything beyond the screen here in the inner workings and wafer boards of the monitor, anything that you and I can't physically touch or assess. So it is checking all the connection points on wafer boards and defibrillator settings and everything else, and saying all the inner workings of my device are good, but we have not checked it beyond that. So you and I are going to check the user test settings. So beyond the wafer boards of the self-test, when we do a user test, it's going to perform the same kind of wafer board and functionality checks on all the electronic inner workings of the buttons, the selector wheel, and our modules over here. But even the user test leaves one last thing unchecked, which we're going to want to check as well, and that is the therapy cable. So that's what the test load is in the back of this. So we'll just run through this real quick. I came in at 9 a.m. I appreciate a self-check passed receipt hanging out the front. If I appreciate a self-check failed receipt hanging out of the front, when I power on the monitor, it's going to give me a red light on the wrench up here that's going to let me know this monitor is not in service. It'll let you know you don't want to use this until it's fixed or serviced. So I turn it on, I have my self-test passed. I'm going to hit Options, using my speed dial, select User Test, and you'll see that it's charging to 10 joules. 10 joules is a perfect amount of energy to check the monitor, the internal charging and defibrillation wafer board, and 10 joules is a perfect joule setting to check the therapy cable. So while this monitor is running through its user test, I'm going to reach into the back and I'm going to grab the test load. I'll go ahead and get my therapy cable out, which in this case it's connected and ready to go on a combo pad. So I'll go ahead and let that loose for now. And I'm going to pull out my therapy cable, and LifePack is wonderful because they give you about an 11-foot therapy cable to reach from the monitor down to your patient. And I'm going to do a quick visual inspection, looking at all the usual strain points on the cable from being stored. Again, checking for shiners, checking the how well it's coiled up, looking at my strain point here at the connection, and just looking inside and looking at the pins. The test load only goes in one direction, so we'll go ahead and attach that. And now it's closed the circuit, and it thinks that we now have a patient in paddles view in asystole. So that's another visual indication that the test load has completed the circuit. We're ready to defibrillate the test load. Now listen, you can charge and shock the test load to 360 joules. I'm here to tell you that this thing is capable of taking that as a monitor check. But I'm also going to tell you that that is unnecessary. You're really only checking the circuit of the therapy cable, and what the engineers at Physiocontrol will tell you is that if you test load this every 48 hours to 360 joules, you'll get about a year's use out of the test load. It'll need to be replaced. Whereas if you test this at 10 joules, you'll get probably a lifetime of use out of it. So I'm going to go on down. My user test is passed. Kind of heard the printer give me an error message, so we'll just check our printer and why it's bunching up in here. There's about a week's worth of self-checks that was bombed up in there. So I'm going to go ahead and scroll the power or the joule setting down to 10 joules. I don't like to hold anything that I'm shocking, so I'm going to go ahead and let that go. I'm going to go ahead and charge to 10 joules. I'm clear, you're clear, everybody's clear. I'm going to push and hold the shock button. The monitor screen cut out and cut back on, and it told me that the energy was delivered. So I know that my therapy cable now just passed. So we have confirmed that the monitor did a self-internal check at 3 a.m. We've done a user functionality check, and we've ensured that the therapy cable was the last part of the daily checks. This therapy cable is good to go. It's really bad when you figure out that the therapy cable's not delivering the energy at the moment the energy needs to be delivered. So that's why you want to do a test load on this at least every 48 hours, if not, every day, depending on how diligent you are with your truck checks. Now, putting the therapy cable away, again, the biggest problem to cause the therapy cable to fail would be unnecessary cable strain. So we're going to go ahead and kind of roll this back on itself. We're going to find a nice little cozy spot for it in the bag. If you can pre-stage your pads in a sealed container, great, but do not open up a container and pre-connect your pads if it's not offered in an option like this. In our climate, any open electrode is only good per manufacturer for 24 hours. So make sure that you're not leaving electrodes unwrapped out of their package for more than 24 hours. Now, again, those ones are designed to be set up that way. So that's great. Okay, now I was going to talk to you about hooking up the 3-lead EKG wire. So as I go to do that, and I pay this out to my patient, we've already talked about where we'd like our patient to sit. I'm just going to hook this up to the rhythm generator to make this a lot easier to run our next portion of this, which is going to be 12-lead EKG and patient data entry, or patient demographic entry. This is a good time to talk about how you set up your monitor. You don't need 100 packages of electrodes over here, but you need enough to perform your EKG. Personally, I think we should standardize the way that we load out our monitors, because you never know which monitor you're going to be tasked with from moment to moment. Give you this scenario: you jump in with another unit that's transporting a patient, and you don't want to have to be rifling through their monitor to see how they've loaded it out. So I think we should standardize that if you'd like. We're going to be putting enough EKG 4-packs off to the side here, unopened, not opening these and moving them to a Ziploc bag, because again, once you take them out of the manufacturer's packaging, they're only going to tell you they're good for 24 hours. Then you need to discard them. So it doesn't save you that much time to just take them out of this package versus a Ziploc bag. I also like to see our bottle of aspirin staged near the 12-lead cable. If you think about it, when you're giving aspirin, it's only for one reason, and the aspirin always correlates with the monitor 12-lead assessment. So we're working on getting that standardized as well, to where the aspirin lives with where it needs to be living. I like my aspirin bottle to be right next to my 12-lead cable. So in the meantime, I'm administering aspirin. My partner's wiring the patient up for a 12-lead. So now I'm going to the monitor, and you'll see that the default setting, we don't have the patient connected to pads, and we don't have end-tidal CO2 going on this patient. So even though I've wired them up, I need to make some adjustments. So I'm going to depress the lead button, and I'm just going to head on down to 2.3 and AVF, and I'm going to get a good waveform of EKG across my screen. Now, you'll notice that in the LifePack, we have a modem that's affixed to the device, and it's going to be capable of wirelessly transmitting our signal through the cradle point in either the engine or the rescue, and shooting that signal off to the hospital when we transmit. Now, before we talk about patient demographic entering, I think it's important that we discuss why we have to enter the demographics correctly and concisely every time. It is really, really, really difficult to run a cardiac call flawlessly to the point where we identify acute coronary syndrome, transmit that EKG to the definitive care physician, for them to interpret that and make some really time-saving decision-making at the ER. And the one thing that has to be correct is that the patient's name is printed out at the hospital on that EKG correctly, spelled correctly, and that the patient's date of birth, age, and gender are also visible on that 12-lead. If we miss that step in our data entry on scene, then we've just taken a very, very wonderful service away from that patient. We may have actually delayed something which is designed for us to shorten, which is first medical contact to reperfusion therapy in the cath lab. So when we talk about entering demographics into the monitor, it's more than just a preference of the EMS division or a preference of Bernalillo County Fire. It is literally a step that's been a long time coming so that we can really make a very, very positive impact on somebody's outcome. If your heart's going without adequate blood flow because of acute coronary syndrome, and it's a matter of me putting in a date of birth or a name spelled correctly, that's going to save 10, 15, 20 minutes of muscle, you can see that this isn't as necessarily a small portion of this interaction. It actually turns out to be a very big portion of the interaction. So I hope that I've articulated that well enough to you. And so here's how we're going to do that. Now, I'm going to put a patient name in here, but how do you get faster at doing this? That's simple. We talked about our pre-monitor checks at the start of our shift every day. I enter a patient name and a date of birth every time I turn this monitor on and do my monitor checks. I'll do the last name is A shift, first name is A shift, last name is monitor checks, and I'll put in a correctly configured birth date. And so let's talk about that. I need to enter the patient's name, options, going to my speed dial, patient, last name, K-I-N-G, and first name, M-A-T-T-H-E-W, because that's my given name, and if I have a medical record, I'm going to want my patient name to be as close to the correct given name as possible. What we see a lot in our system is we see a lot of seniors and juniors. So if my father's Matthew King Sr. and I'm Matthew King Jr., and we've both been going to Presbyterian or UNMH our entire lives, our medical record, it's going to be difficult for them to figure out if I'm senior or junior if the next step is to look at my birth date. So make sure you're doing the correct patient's given name. Now patient ID, that is going to be where you put the date of birth. So let's configure that correctly. You can see that if I were to put 5/21/78 and I were to simply leave it in that configuration, let's think about the person on the other end of this transmission interpreting this EKG that's going to print out on a printer next to them, next to a phone, that they're going to call and say, this is patient Matthew King coming in with what looks to be a pretty bad acute coronary syndrome, but they don't have their date of birth on here because they're going to see this weird configuration of 5 numbers, and they don't know if that's a number that the monitor's auto-generated or something that the printer plugged in there. How do they know that that's a birth date? The only solution is to make it in such a way that I just tell people, if you were to read this paper and you didn't enter the data, would you know that's a birth date or not? That's the correct answer. So we'll go back and make that correction for the patient ID, and we're just going to go 5-21- and it's going to be 1978. Now, do you see how that looks a whole lot more like a birth date versus the other way that I did it? That's the thing, is you need to make sure that, you know, we're saving time, we're saving heart muscle here, and something as simple as a data entry misstep could become a real hindrance for getting what we want to have happen. Now we need to make sure that we do the correct age. Yep, it's 40, and I'm happy about it. And the gender. And so we're going to go gender. Double check here while the screen's still hot. King Matthew, birth date, age, and gender. We're good, and we're ready to go ahead and transmit. If you get really, really good at this, I'm here to tell you that you can transmit 12-lead 1 if it's a good, clean, interpretable 12-lead. Transmit that from the living room of the call, and we'll get into transmitting EKGs here shortly. I've been on the phone with the hospital, and I'm sitting with the patient, and I'm saying, I'm sending a STEMI in with Albuquerque Ambulance Unit 3054. It's a 40-year-old male with acute coronary syndrome. I'm transmitting the EKG to you now. Let me know when you get it. And they've received the 12-lead before I disconnect that phone call. We haven't even left the scene yet. They're ready to activate the cath lab, call the people in that they need to call in, and the patient has a very, very good outcome just by some simple data entry steps. So it's not small potatoes to say that we need to enter data correctly. It's really going to make a very sound clinical decision happen for your patient. There's nothing more than patient advocacy to this extent, so I hope that you'll incorporate it into your practice. So it's all the data entry we talked about, name correctly spelled, junior, senior added if it's needed, the birth date entered in a configuration that somebody will say that's the birth date when it prints out in the hospital, and the age wheel turned to the correct age, as if you're doing a juvenile or adolescent or child EKG, and let's say we scroll that down and we're doing a 12-lead on a 13 or 10 or 7-year-old male or female, Lifepack15 is going to make some adjustments in the way that it's going to interpret that. It knows that it's a pediatric EKG, and it has some other electrical considerations to do for its own interpretation of that EKG. So by entering the age and the gender, it's going to go ahead and make those adjustments, something that you and I won't be able to adjust. And when we print out that EKG and we now go to interpret it, Lifepack has helped us out by ensuring that that what we're seeing is what we're seeing, versus if I don't make that age adjustment and it defaults to a 50-year-old, but it's actually an 80-year-old, you can see how the electrical data that it's sending is expecting to send me an EKG of a 50-year-old female or a 50-year-old male when it's actually like an 82-year-old male and not a female. So we got to get that data entered in quickly and efficiently, and it needs to be correct for those reasons. So that's the heart of patient advocacy, again, is to a few tiny steps, if done correctly, can make a world of difference in 10, 15, 20 minutes. I know if you're having a heart attack, you sure would like that heart to be reperfused 20 minutes earlier, and you don't want it to be delayed because of a simple data entry issue. So it's important stuff. So we've made patient contact and we've prepared the patient for a 12-lead acquisition. Again, our person who's wiring the patient up has taken the time to explain to the patient what our goals are, and that is to minimize patient movement, to use electrodes out of the manufacturer's packaging and nothing out of a Ziploc bag. We want that to know that our electrodes are going to give us the cleanest tracing possible. If electrode's been out of the manufacturer's packaging for more than 24 hours, it just leads to poor quality EKG, which is probably not interpretable, in which case you're going to have to delay in putting new electrodes on, troubleshooting that. And if we transmit with the correct name, age, gender, a date of birth, everything we talked about for a successful EKG transmission, to shorten the amount of time that patient has to wait for their reperfusion therapy, if it's on account of electrodes that were just placed in a Ziploc bag, it just doesn't make sense. So make sure that you use electrodes, you're not pre-staging them on the cables, you're not saving yourself any time by doing that. So here we have our patient wired up for 12 lead. Again, we've explained to them that we need them to hold still. The person who's been acquiring their vital signs is still sitting with the patient and they're coaching them through the EKG. It's going to take about 7 to 10 seconds for the monitor to pick up an EKG. So let's go ahead and enter our patient demographics and get ready to send this EKG. So here I'm going to hit options and patient, and we're going to enter our patient name. This, of course, is going to be Vanessa Smith. Thank you, Ms. Smith.
You got it.
Correctly spelled. Date of birth, please. 1/31/81 with dashes.
1981.
1981. Dashes. Verify the patient's date of birth is correct. Patient is 37 years young and female. Vanessa Smith, 1/31/81, 37-year-old female. Good. Got a home screen. Patient, we're going to ask you to hold as still as possible, breathe normally, and we'll get this EKG in about 15 seconds. I hit 12 lead. It's not going to prompt me to add any more data. And as the monitor is going ahead and interpreting our 12 lead and getting ready to prepare it for us, now we're going to see what the hospital is going to see when we prepare to transmit this EKG. Notice how we used fresh electrodes, coached the patient to stay still, entered the demographics correctly, and now we have a nice clean EKG to interpret. Now, if you're receiving this at a hospital across town and you're not here on scene, you're going to see that as this prints out on my printer in the hospital, I go, oh look, I have a Vanessa Smith with a birth date and a gender and an age on here. I can look this patient up in my system and start getting the ball rolling towards the end game, which is to get them reperfused. So it's very, very important that we do that. I believe this is set to auto transmit, yeah. So that's okay, it transmitted to CodeStat. So now we're going to go ahead and we're concerned that the ER is going to want to have an early notification on this EKG. So the patient's still wired up. We're within a decent distance between us and the cradle point, which is either in the engine or the rescue. This monitor will sync up to either one of those. So that sort of speaks to if you're in a spare unit without a cradle point, you're not going to be able to transmit this thing wirelessly. You're going to need to be in a unit that has a cradle point in order for this to transmit successfully. But to transmit right below 12 lead, you're going to want to set your report, which is not all. We just want to pick one 12 lead, because if you hit all, the file's still building on this monitor because it's running and it's gathering data right now. So if we send all, it won't be able to send that file because the file's still building. So we just want to send 12 lead 1. We're going to pick our site, whichever hospital. You'll notice that the hospitals with cath labs are listed. So you don't want to send this EKG to an ancillary facility where the patient can't get the reperfusion therapy they need. And for the purpose of this, we're just going to send a test. And we're going to hit send. Pay attention to what the monitor is telling you. It says attempting to transmit, transmitting, and now it's counting up in a percentage as to how much is transmitted. When I've been on the phone with the hospital and I've called all of them, sending them test EKGs, when this thing hits 99% transmitted, the EKG is printing on the printer at the facility. So you don't necessarily have to wait for 100%. As soon as you see it's hit 99%, the EKG is printing somewhere, and somebody's going to be grabbing that. And then you'll also get this verification receipt here that the transmission was completed. If the transmission was failed, you're going to need to start troubleshooting as to why it's not transmitting. Ask yourself, do I have a cradle point? Is the cradle point working this morning when I checked my truck and my MDT? Am I within a close enough range to hit the transmit successfully? And if you can't answer all that and troubleshoot it, then you're going to go back to your original plan, which would be to contact the ER you're transporting to and give them a verbal alert saying, I have a STEMI verified on EKG. We'd like you to go ahead and activate your cath lab. We'll be leaving here and see you in about 20 minutes. And then follow up with them if the patient's clinical picture warrants it. So that's 12-lead EKG. Okay, so end-tidal CO2 monitoring using the oral nasal sampling cannula provided for the LifePack15. This is going to be rolled out on any patient in which you're concerned about their respiratory status. So if they're complaining of shortness of breath, you're going to be administering medications to treat breathing, and you want to have a objective picture as to how well or how not well your medication interventions are going. This tool is invaluable to you to figure out what's your patient's respiratory status. Unlike your pulse oximeter, BP cuff, and EKG cables that are all very, very sensitive to any kind of movement and artifact, end-tidal is not very sensitive to patient movement or artifact. Where end-tidal will stop working on you is if the heart stops. But other than that, as long as the patient's breathing, they can move around and sneeze and do everything they want, talk to you during your clinical interview, and it's really not going to affect the sample that you're getting from them. You can run into some pitfalls with this when you're unpackaging it, so I just sort of tell people to prepare themselves to unroll this correctly. So what you're going to want to do is I like to go to the monitor before I go to the oxygen bottle, is I like to unwrap this and separate the two, and you can see how if you don't pay this out correctly the first time, it becomes sort of a headache to correct it. So you want to sort of find the way that the cannula is paying out. You're going to grab it, and you're just going to do one of these jobs right here and separate it. Otherwise it becomes a tangled mess. You have your nasal prongs, which are kind of long for an adult, and if you're going to use this on a pediatric and you have your shears, it's okay to go ahead and trim those down a little bit if you think they're going to go too deep in the nostrils and make the kid, not necessarily like having this cannula stuffed in their nose. You can trim those down, that's okay. You'll notice the diameter of the nasal prongs is much smaller than that of the traditional nasal cannula for adults that you see. That's a limiting factor for you to keep in mind, that for high flow nasal cannula applications, this wouldn't be something you would use that for. We don't do high flow nasal cannula necessarily in our system, but if you're going to pre-oxygenate somebody that you're about to snow for intubation, you wouldn't be able to do that with this nasal cannula, so keep that in mind. We'll have the patient apply that correctly, the oral sampling cup towards the mouth in case they're mouth breathing, and the nasal prongs in the nose in case they're nose breathing, or a combination of the two. You'll notice at the distal end of the sampling cannula, you have electrical connection point here. This little metal ring that's on the end, when it's inserted into the monitor, turns on the end tidal mode. And if you were to unscrew this, the only way to turn that module off would be to cycle the monitor off. So once you commit to end tidal monitoring on this patient, it's best to continue that process until you're ready to turn the patient over to another device, or you want to turn this off and turn it back on as a new file, but then you're going to have to enter all your data again. So this is a commitment. Once you start sampling somebody, you're going to monitor it from the moment you plug this in, so keep that in mind. You'll also appreciate a very small paper filter that's at the far end of this. If there was blood, mucus, any kind of secretions from the patient's airway, it will advance down the tubing throughout the process, and this is the last-ditch effort to save that secretion or blood from making it into the monitor itself. So you're going to want to monitor that, and if you're dealing with blood or any kind of gross purulent secretions, and I just say if it's getting about halfway through the tubing, swap them out with a new fresh cannula. You don't need to necessarily wait for the goo gauze to get all the way to the filter before you change it out. So things about the obvious and not so obvious about these devices. So we're going to go ahead and introduce it carefully. It's a quarter turn to set that in place. You notice that it turned the module on, end tidal, and the first reading it's giving us is her expired carbon dioxide. And I want to monitor her breathing, so I'll scroll down to channel 3, and I'm going to change that to CO2. And we'll just sort of let things stabilize here. And this isn't necessarily a capnography class, but you're going to want to appreciate the readings that you're seeing. So we have a respiratory rate of 14, an end tidal value of 32, and we have a good waveform here. Now, let's say we're treating somebody with some kind of reactive airway disease or chronic obstructive pulmonary disease pattern, and we see some narrowing and some shark fin, and we're going to employ CPAP, for instance. I suggest that you use the end tidal sampling cannula and do the CPAP over that, because the way this gives you a value is the closer you can get the sample to the patient's airway, the better. If you were to, for instance, try to do a side stream sample off of your CPAP really far away from the patient's exhalation, it's not going to be as accurate for you. It'll work, but it's not going to be optimal. If you want to really optimize what you're seeing on a patient, you really need the sample to be as close to the lungs as you can get it. So now we're going to see if our clinical picture is improving. Another case where you're going to want to use this, consider any, per protocol, if you're going to give any medication through an IV or an IM that has the ability to lower a patient's respiratory effort, for instance, Versed or morphine or fentanyl, any kind of opioid, or ketamine now, if Albuquerque Ambulance is rolling out a medication that could alter respiratory, you're going to need to or objectively monitor the patient's airway and breathing status. So just throw one of these devices in place and voila, the LifePack's monitoring it for you. The patient can move around as much as they want, and it's not going to change much here. You don't get artifact from patient movement. If the patient were to stop breathing, then you can just take that off. The monitor is really quick to let you know that you've had a change in the patient's breathing status. Notice how we went from a waveform to no breathing whatsoever. And it's going to say here in a minute, we have a problem, reevaluate your patient. And that comes in the form of an apnea alarm. There goes. So notice how the timer kicked on and it started at 30 seconds and it's counting up from there. So even though it wasn't alarming, it tells you right there how long the patient has been apneic. It gave us 30 seconds for the patient to spontaneously start breathing again, or for us to see that the cannula had fallen off. But it started counting up from 30 seconds and above. So it's okay to hit alarm and silence that alarm, but you're really just silencing the alarm. You need to figure out what's wrong with your patient clinically, and you can silence it for a short time, and then it'll alarm again in another 30 seconds saying, you silenced me, but you haven't fixed the problem, we're still not breathing, and it's not just going to let you, silence and forget it. So again, another wonderful clinical monitoring tool, another way to gauge if your treatments are going in the direction you want them to, and whatnot. So end tidal. Now, the critical patient who you've now introduced an extraglottic airway or an intubation or something on, there's a whole lot more considerations with intubation or airway monitoring that you're going to want to employ. But all of it is the exact same thing that you're doing, you just don't have the benefit of communicating with your patient to see if you're going in the right direction clinically. So we don't necessarily need to get into that on this discussion. This is really just familiarizing you on the clinical tool of end tidal and your LifePack. So let's just show now that we're going to put the patient back on pulse oximetry, which we've covered. We'll let the pulse ox come around and start giving us a pulse heart rate. So now that I've got a good waveform and I'm watching my patient's breathing status, their end tidal, CO2 number, their waveform on the capnometry reading here, I see I have a scale of 0 to 50 with an end tidal of 30, so that graph's going up to about where the 30 would be on that scale. And I've introduced my SpO2, and I want to see if I'm oxygenating well as off-gassing CO2. I can go back down here and change my waveform from EKG to SpO2, and notice how this changed color from green to blue, and that graph is in blue on the SpO2. So if I wanted to turn off the volume on my pulse oximeter and rather listen to the EKG, the QRS volume, I'm going to get the same result. I'm going to hear a beeping heart rate. But doing a EKG QRS volume isn't necessarily as awesome as the pulse oximeter heart rate, and you have to ask yourself why. This is just indicating that the monitor sees QRS complexes, and it's going to give me an audible beep for every time it sees a QRS complex. But if I go over here and she's not having a pulse, then I'm going to mistakenly think that I have a patient with a pulse because the QRS volume is registering and it's actually PDA. What I'm going to rather choose to do is turn off the QRS volume, scroll down to my SpO2 volume, and turn that up. Now I know that I'm picking up capillary blood flow pulsations at the finger. I have mechanical activity, I have a pulse, I don't just necessarily have a rhythm. So those are the two differences between QRS volume and SpO2 volume. And you see this beautiful clinical picture that I have now. I have a good monitoring of lead 2 and the EKG. I have a plethograph reading for blood flow to the fingertip with a pulse oximeter and an audible pulse to listen to that I have mechanical heart activity. And I'm watching the patient's respiratory status very, very closely. All of this in a matter of moments as I started my clinical assessment. The monitor's on the patient's left side. Everything's paying out to the patient's left side correctly so that I can do interventions on the patient's right arm. And we've made this entire interaction work very well for a very comprehensive assessment in a short amount of time. And if we decide to transition to transport, things are going to go flawlessly at this point. All because we made some very obvious considerations from the outset. So now we have an entire set of objective vital signs for our patient's initial clinical picture with a heart rate sat, respiratory rate, end tidal, and a BP. And if I want to share this information with the person conducting the clinical interview without interrupting their interview and hollering out vital signs, I can simply just hit Options, Print, tell it that I'd like to print my vital signs, and pay that out. And without interrupting the clinical interview, in the middle of our assessment here, I can basically hand off a copy of vital signs to whoever's leading the interaction. And if we want to set off another, or burn off another set of vital signs to the transport agency, they know exactly what time we took our vitals. Any events we put in for giving any medication or starting IVs or starting oxygen, all that can be passed on to somebody without really 5 people in the room talking. So you can really make this monitor work incredibly efficiently for your patient interactions once you get used to pushing the buttons and using all of the features together as a crew, and practice makes perfect. So make sure you guys are working on it together, guys and gals. Another great thing about the LifePack15 is that the most common interventions that you're going to make are listed in the events section. So rather than having to look at one person's watch or a timer or figure out when we gave an intervention, we can go ahead and timestamp it here. So we'll just, for the case of showing off the features, we'll just work this as a normal typical chest pain call, because that's got a lot of interventions involved. We made patient contact and powered on the monitor when we did that, so later we know when we actually made physical patient contact. We've deployed all of our vital sign gathering equipment and gotten a complete set of vital signs, which have timestamped when those were obtained. And now let's say we've the patient's clinical picture called for the administration of oxygen. So we're going to go ahead and hit event and scroll over to oxygen. Another common intervention for chest pain would be to administer aspirin. So we'll go ahead and timestamp that aspirin was given. And again, I like to store my aspirin where I'm going to use it, so I'm going to get my aspirin out and administer that. Now somebody perhaps has gained IV access. We'll just scroll over, hit event at IV access. And another intervention that might be performed, we'll just say we're running an old school AHA code, is we've given the first dose of nitroglycerin. That's put in there. And all this is being done without a million people hollering out, aspirin's in, oxygen's in. Later when we go to document, we're going to have all these interventions listed on here as well. Perhaps we're now moved on to morphine, and we've completed and rounded out the MONA acronym for our ACS patient. And now we're going to pass on our vital signs. Again, we'll go to options, print, change this to vital signs, and we'll burn this off, and we can pass off all of those timestamps of all of our labeled interventions off to whoever needs to have a copy of this. And it's a very, very professional and methodical way of inputting patient demographics, patient interventions, using the LifePack, and making this interaction go even more smooth than it did before. So by getting used to inputting all of the data you can using the events wheel and the demographics, it's going to really shorten and improve the accuracy of your ePCR when you go to generate your ePCR later and you're charting your procedures, your interventions, your time of 12 lead, your time of pacing, your time of defibrillation, whatever the case may be. This monitor is going to give you a beautifully, perfectly time-stamped display of how well the call went for you. And I know we all get kind of worried about, what if I made a mistake, or what if I did something out of order? We're humans and we make mistakes. That's one thing about the monitor and using it in this configuration, is that it has the ability to highlight when we're having some shortcomings as a department, and that way we can roll out some corrections as needed. So I highly encourage you to get used to using all of these event wheels as well. Soon, this monitor, once you power it off, is going to auto sync all of these up into the cloud, and all of this data will be available for you to pull down into the new charting software Image Trend, and it'll shorten the amount of time it takes you to do data entry for your charting. So you're going to be at the computer a lot less time after these calls, and getting back to studying up on the other features of the LifePack with all your newfound downtime. So thank you for taking the time to go over some of the features of the LifePack and some of the considerations you may have appreciated before, or maybe you didn't. Hopefully you came away from this learning something new. And if you have any questions that you think any of us can help you with, contact the EMS training division, contact me if you'd like to. I'm on A shift 35 for this current bid year, and if you need my phone number, it's out there as well. And I just really would like you all to be really satisfied with how much better your clinical assessment can be incorporating some of the features of the LifePack that you may not have been using before. So thank you for taking the time to go over this stuff. It means a lot. Pulsatile beats at the capillary level.
So Matt,
Yeah.
let's make that really easy for me to
Yeah.
edit out. So go back to things that you might not appreciate,
Okay.
and then pulsatile.
Okay, you got it.
Wicked editing skills these days. Yeah.
Kind of heard the printer give me an error message, so we'll just check our printer and why it's bunching up in here. There's about a week's worth of self-checks that was bombed up in there.